Yeah, this was a, a large phase 3 trial, an investigator-initiated trial, so an academic trial that evaluated different venetoclax-based combinations, so venetoclax-obinutuzumab, venetoclax-rituximab, and venetoclax-obinutuzumab-ibrutinib for the first-line treatment of patients with CLL. Yeah. Yeah, the study design was a four-arm trial with three experimental arms. The three arms I just mentioned, and the control arm was a standard chemoimmunotherapy arm with FCR for the younger patients and BR for the older patients. And then patients, in total 926, were randomized in a 1-to-1-to-1-to-1 fashion to these four arms. And then the primary endpoints, there were two of them in this trial, were on the one hand, the undetectable MRD rate after or 2 months after the end of treatment, so at month 15. And on the other hand, progression-free survival comparisons between the treatment arms. So the main results that we've already published before as well were that the venetoclax-obinutuzumab arm, so venetoclax-obinutuzumab and the triple combination of venetoclax-obinutuzumab and ibrutinib, they were both superior in terms of PFS when compared to both the venetoclax-rituximab arm and the chemoimmunotherapy arm. And what was new now in this with this longer follow-up was that also the triple combination with ven-ob plus ibrutinib showed a significantly longer progression-free survival compared with the doublet of ven-ob, which is one of our standard treatments in Europe. And this was quite a big PFS difference at 5 years. I think it was around 80% for the ven-ob ibrutinib arm and around 70% for the ven-ob arm. And this was the main PFS result, which was driven by, or this difference was driven by very distinct differences between the IGHV unmutated patients. So patients with an unmutated IGHV status, they benefited very much from the triple combination, whereas in patients with mutated IGHV, we didn't see any differences between these two treatment arms. Then we had some overall survival data, and this overall survival data confirmed what we've seen before, that there is no difference in overall survival between the treatment arms. And safety-wise, there were also no new safety signals. We did see a little bit of excess cardiac adverse events and a little bit of extra incidence rate or higher incidence rates in infectious adverse events in the triple combination when compared to the doublet. But in general, the safety profile was very, very well tolerated, or the drugs were very well tolerated. Yeah. Now, that's a good question. We've also discussed a lot in the consortium that led the study, because on the one hand we see a PFS benefit for the triple arm, and we somehow have to do something with it. But on the other hand, we are all very hesitant to use the triple combination in the first line setting due to the excess toxicities, due to an impaired quality of life of the patients under treatment. That's something I didn't mention before, but we did see impaired quality of life with the triple combination compared with the doublet, and also we don't see any overall survival difference. And also the problem, if you already give all the three different drugs in the first line, is I think that it's not as easy to treat these patients again in the second line, and that's why the clinical significance of this PFS difference is maybe not as big as it might seem when you see the PFS curves.